Okay, hello everyone. Good afternoon. We have our external seminar now. Esperamos. And it's a pleasure to have Marc here finally. I really don't know why you were not invited before.
I don't know.
Because I think it's kind of like we need to know what he's working on, because it's gonna be like really cool for us to collaborate. I had the pleasure to not work with Marc ever in our lives, but we have been enjoying, surviving the biomarker course, but also enjoying it for a few years now as directors. And actually, I think we were talking last week that probably we overlapped in Gothenburg for a couple of months when I was doing my PhD stay.
Yes, I think so.
You were there as well. So I think our paths have been crossing for a few years. But yeah, Marc is the head of the Fluid Biomarker Lab at Barcelona Beta Research Center, and yeah, he's here to talk us about all the fluid biomarker projects that they have been developing there. So thank you very much.
Thank you very much. Thank you, Aitana, for this very nice presentation, and thank you for Pascual for the invitation. It's a pleasure to be here. Yes, it's the first time. I'm sorry for my voice. The first time I'm here in Fundación CIEN, and I'm quite impressed. I think that you have a very nice group, not only the infrastructures and everything, but a very familiar group I have seen, and this is very nice to work with people that you get on well. So. Sorry, today I will talk about, of course, blood biomarkers, but I will try to talk about what we do actually in our group, that is starting for very basic research about the biological meaning of the biomarkers, and then going really to the implementation. I myself, I'm a clinician, a neurologist, I see patients, but I also have a background in biochemistry, so I like to do this, what is so-called translation, that it's a very bold term, but that's what we are trying to do, to see patients, ask questions, then bring it to the lab, and then try to answer some of these questions to the lab and bring it back to our patient. So maybe it will be a very general talk about a lot of things, but yeah, I want to talk about all of this, of all the continuum from the lab to the clinics. So this is Paula and Felipe from this is my lab, and let's talk about the basic things. First of all, something that I think that you know very well, the importance of the continuum of Alzheimer's disease. It's not only about dementia due to Alzheimer's disease, but it's important to understand all what happens before. This is 20, 30 years. And actually in Barcelona Beta, we have a cohort which is called the Alpha study, which is the aim is to study this preclinical stage of Alzheimer's disease. So these are cognitively normal people, but many of them are amyloid and tau positive with the biomarker, so we can study this preclinical stage of the disease. This is something that maybe now sounds quite obvious, but 20 or 15 years ago, when this study started, it was not so obvious. And now we are in this turning point in which some of us can not only detect this stage, but we are now doing clinical trials with anti-amyloid drugs and other drugs interventions in this early stage. And the future is prevention. So that's why it is very important to go also in this early stage. And in fact, a few years ago, we described, this is Marta Milá, my first PhD student, how some of these plasma biomarkers, this is in cognitively normal people, but some of them accumulating amyloid in these centiloid scales, and a few of them even with not very high centiloids, some of these plasma biomarkers, especially the phospho-taus, increase in this preclinical Alzheimer's disease. This is a work together with the Gothenburg group. Not only this, but this is an association with amyloid PET. This work was done by Gemma and Mana, and some of these phospho-taus, not amyloid by the way, more of these phospho-taus are associated with amyloid PET deposition in very early stages. G5P, which is an extremely interesting biomarker. That is, by the way, there are sex differences that are very interesting in G5P. It's always higher in women than in men. And we describe also that G5P increases also in very early stages of the diseases, in preclinical Alzheimer's disease. And very interestingly, plasma G5P probably is the only biomarker that is better, G5P, in plasma than in CSF, for whatever reason. Probably there are some technical reasons, but G5P is more stable in plasma than in CSF. But maybe there are also biological reasons. G5P is astrocytic, the feet of the podocytes of the astrocytes are in the blood-brain barrier. Maybe we see more G5P in plasma because there are the astrocytes that are in the blood-brain barrier. Something that I would also like to highlight, and this is something that 2 weeks ago I have the opportunity to explain it in Manchester in AAC Next, is that when we talk about biomarkers, it's also good to take into account that we are not only talking about things that we measure for diagnostic purposes or that have a clinical utility. Sometimes biomarkers give us a lot of information about the disease, even if that does not have a clear clinical utility at this point. And one example is SOLO2 that I used to work a long time ago, a protein that is specific of microglia and really describes not microglia in general. There are no biomarkers of microglial activation. There are biomarkers that indicate specific phenotypes of microglia. TREM2 is associated with a phagocytic phenotype of microglia. And what we could show at that time is that higher levels of SOLO2 is associated with a better prognosis, a moderated cognitive decline in several stages of the disease, in ADNI, in DIAN, and in alpha. The measures actually for SOLO2 in ADNI are publicly available. We measured them years ago, so you can use it if you want. This is just an example, but let me give you another example from a PhD student from my group, Felipe, who is working in, we are working in those factors that are associated with brain aging. And we're studying cloto. Cloto, it's a protein that has been described as having a rejuvenating effect on the brain. It's mainly synthesized in the kidney. Kidney is quite interesting because when there are these studies of Tony Viscorese in which he calculate the organ-specific age, biological age of an organ, and the biological age of kidney is quite associated with the brain age of brain. So kidney seems to be quite important for the brain. So Felipe measured cloto in our alpha cohort, and what he has shown or he has seen is that also there are sex-specific effects. What we see is that in preclinical Alzheimer's disease in women that are preclinical, that are amyloid positive, higher levels of cloto are associated with lower levels of some of these biomarkers of Alzheimer's disease. But specifically in women that are amyloid positive and cognitively normal. So again, a sex effect. Again, I'm not stating here that cloto is useful for diagnostic or it's giving us any clinical information at all. We will not measure cloto in the clinics, but it's helping us to understand the biology and how these peripheral effects may have an effect on the brain. Now let me show a little bit more about this biological meaning of biomarkers, and this is a work that we are working. Federica, a very talented postdoc in my group, she has done, she's studying the proteomics, and in particular, this is a kind of a diagram of the alpha cohort, because the alpha cohort, again, is cognitively normal. Some of them are amyloid positive. We have followed them for more than 10 years, and every 3 years we have a visit. So we have, in what we call the visit 3, we have in blood measurements of our link and soma scan. And then we have followed these participants for a long time, and we have every 3 years the PAC, which is a composite, a cognitive composite, which is quite sensitive to changes in these early stages. We need to do that. If we did a Mini-Ment or something like this, would be completely useless, because obviously these are cognitively normal. A few of them, but very few, progress to MCI, but most of them do not progress. But there are changes in this PAC. And these changes, we were discussing it before with Aitana and Pascual, more than really a true decline. It's most of the cases a lack of learning effect. But Federica, what she did is to try to test what of these proteins are associated with cognitive changes, good or bad changes, both. And actually we see several biomarkers, several proteins that are associated with cognitive changes. But the most striking finding is that there were, again, lots of differences between men and women. So these are the proteins that are associated with cognitive changes, again, in a protective or detrimental way. And we were expecting that maybe some of them are more specific or significant in men or in women, but most of them would overlap. And it's not the case. Only 3% in Olink and 4% in SomaScan are exactly the same in men and women. So the blood proteins that are associated with cognitive changes in preclinical Alzheimer's are completely different between men and women. Actually, here you see, I show here, this is very preliminary analysis. This is, Oling, the proteins. And as you see, many of the proteins are completely different. There are interesting proteins. For example, in men, we see lipocalin 2, that maybe someone rings the bell, but this is a protein that is very associated with vascular injury and amyloid angiopathy, and is associated with a worse cognition, but in men, not in women. So many proteins that are specific for sex. Oops, sorry. This is talking about exactly preclinical Alzheimer's disease and the meaning of the biomarkers. Let's go now to the clinics. So I think that at this stage, many of us, we are using the biomarkers in the clinics. We usually in the hospital, in the routine clinics, because actually they have shown that work very well. And I think that many of us have already measured these plasma biomarkers in each of our course. What we did is last year, head-to-head study. So in exactly the same patients from our memory clinic, study more than 22 biomarkers. This kind of head-to-head studies are important because if you measure one biomarker in one cohort, another biomarker in another cohort, and another biomarker in a completely different cohort, then it's difficult to compare it. So that's why it's good to have these head-to-head comparisons. But here the good news is that we don't have one or two, we have several really biomarkers that compare to the standard of truth, Daria under the curve, which is the lumbar puncture. Daria under the curve is very, very good. As you can see here, the colors have a meaning, and the green ones are the phospho-tau217s, which are the ones that have a high accuracy against the standard of truth, the lumbar puncture. But there are others, like some 1A ones, that are also very good. So we have several plasma biomarkers that we can use in the clinics and really are almost as good as the lumbar puncture. However, something that is also quite important we have to highlight is that in the clinics, we don't have a group of participants, of patients, and we calculate in that group the area under the curve. We calculate a cutoff and an area under the curve. In the clinic, we do the other way around. We have a pre-established cutoffs, then patients come to us, and then with these pre-established cutoffs, then we decide if that patient is positive or negative. So this is why it's so important to have pre-established cutoffs. And that's what we did last year in a multi-center study in which we established with the phospho-tau217 of Lumipulse a cutoff in the Malmo cohort, and then we validated in other cohorts, including ours. And the accuracy of this pre-established cohorts is also very good in the other cohorts. This is applying the two cutoff approach that probably some of you have heard about it, but basically what it consists is instead of having just one single cutoff that is positive or negative, you have two cutoffs. So if you are above this upper cutoff, then you have a very high positive predictive value, while if you are below the lower cutoff, then you have a very high negative predictive value. And only if you are in between the two cutoffs, you have an intermediate zone in which you are not so sure, and then you have maybe to do the standard of truth, a lumbar puncture, or amyloid PET. And it's recommended that this intermediate zone should be less than 20%, and it's what we show also with these two cutoffs that we calculated in this study. There is some discussion about whether use phospho-tau217 in plasma or the 217 beta 42 ratio. Actually, in the United States, the FDA approved the ratio of a beta 42. But actually, here in our study, what we could see is that the ratio it's not better than phospho-tau217. Even in some cases, in primary care, it was even a bit worse. I think that the fact that in primary care is a little bit worse is not by chance. I will discuss this before. The only advantage probably that has using the ratio is that decreases the people that fall in the intermediate zone. So then you probably have to do less lumbar punctures and amyloid PET. This is the main advantage, in my opinion, of using the ratio instead of only using phospho-tau217 in plasma. This is actually a table that we did with Nick Ashton about the advantages and disadvantages of using the ratio phospho-tau217 beta 42 compared to phospho-tau217 alone. It's a very busy slide, but I think I can summarize it very quickly in the following way. The main advantage is that of using the ratio is reducing this intermediate zone. But the main disadvantage is that a beta 42 in plasma as in CSF. It's difficult to measure. It's not very reliable. It's very affected by pre-analytical issues. And then you have to be very careful, because when you are in the real world, for example, in the primary care, small changes in pre-analytics, in the analytics, can really affect the values of a beta 42. And so this is something that needs to be taken into account in the real world. Also, the effect sizes of the difference between a phospho-tau 217 and a beta 42 between the amyloid positive and negative, in a beta 42, the effect sizes are not so different compared to phospho-tau 217. That means that if there are small changes for whatever reason, for analytical things of a beta 42, someone can change in the group in which you are classified. While in phospho-tau 217, the effect sizes of the differences of the two groups are so different that if there are some things that changes, does not change the classification. So you have to be careful with the ratio, because if you do everything in perfect conditions, a beta 42 adds something. It could even increase a little bit the accuracy, but in the real world, probably it's more problematic introducing a beta 42 than using phospho-tau 217 alone. So my opinion, and probably some people disagree, it's better to use the phospho-tau 217 alone, and it's cheaper. Talking about cost, one thing that we did also is Federica did this Shiny app that you can download, and you can calculate, in fact, how many lumbar punctures, how many amyloid PET, and how many money would you save if you use, at first instance, a blood biomarker using the two cutoffs. And with that, and depending on the price that you put in your center of each of the marker, you can calculate the savings of using the plasma biomarkers, which is also something which is important, of course, when we're talking about implementation. Not only to have scientifically a very good biomarker, but also if you have to go to the director of your hospital and you want to implement phospho-tau 217, you can show this. All right. Another interesting group of patients that we commonly see in our clinics is subjective cognitive decline. Subjective cognitive decline is this kind of patients that have some memory concerns, but when you do a neuropsychological test, everything is normal. And these patients, I would say, that are increasingly, or at least I see more of this in our clinics. In former times, in our memory clinics, we see people that were in the late stage of dementia. Then we started to see, luckily, more people with mild cognitive impairment. And now I think that we see many subjective cognitive decline. And this happens because probably people are more aware about Alzheimer's disease or these diseases. So many people with small memory problems start to come to us. And this is good. But actually, this is also a challenge, because these people probably will not do good enough. Actually, we do not usually do biomarkers, blood, CSF, or amyloid people in PET in these people. What we usually do is to see if they have any problem that we can solve, sleep problems, anxiety, depression, and then we just say, okay, come next year, we repeat the cognitive test, and we see if you are declining or not. Why not doing also biomarkers in these individuals? We have a cohort in our center of subjective cognitive decline, and as you see here, I will not enter into this. We measure lots of biomarkers in order to characterize very well these patients. And again, some of them here, the area under the curve against the standard of truth, the lumbar puncture, and some of them, again, the phospho-tau 217s have a very good area under the curves. Let's focus on some of them, the phospho-taus especially, and as you see in the curve that are above 0.9, so this is great. However, in the clinics, more important than that under the curve and the sensitivity specificity that mainly depends on the assay, it's the predictive values. The predictive values, it's something different. Predictive value consists on you have a positive result, and then that's the probability, the likelihood that having a positive result, you have the disease. This is the positive predictive value. Or you have a negative result, so that's the likelihood after having a negative result that you don't have that disease, that case Alzheimer's disease. The predictive values do not only depend on the biomarker, on the technique in the assay, but also depends on the pretest probability of having that disease. That is the prevalence of the disease. And that prevalence of Alzheimer is quite different in people that have a subjective cognitive decline or people that come with a typical dementia with memory problems. The probability of Alzheimer's disease in this population is lower. So that means that even having a very good area under the curves, the negative predictive value is very high. So in this patient, you have a negative result, you can't really trust it, but the positive predictive value is not very high. So if you have a positive value, you have to be careful. You cannot really confirm that this patient is having Alzheimer's disease. So this is a good example of how biomarkers need to be interpreted always in the clinical context. It's not only about new technologies, biomarkers, and so on. We need actually, I believe, better neurologists, better clinicians to interpret these biomarkers. Yes. It's lumbar puncture, yeah.
I was asking about the gold standard.
Exactly. It's lumbar puncture as well. So we don't usually do biomarkers in subjective cognitive decline, but based on the results, maybe we have to do it, but just to rule out, to exclude the disease, because a negative result, you can't really trust it, but not to confirm the Alzheimer's disease. And here there is a matter that is also very important when we're talking about biomarkers, it's communication. It's also part of biomarkers research, the communication, how we should communicate these results to people with subjective cognitive decline, people that really have not cognitively impaired, the cognitive tests are completely normal. All right, so now I'm coming back to our alpha cohort. So this is not subjective cognitive decline, these are cognitively normal people that are participating, are volunteers in a research study, in a cohort. So it's not people that come to seek medical advice. And here, this is our man, this is the NTK of Roche, and some of the biomarkers, you can see especially phospho-tau217 or the ratio as well, will have very good accuracies to detect amyloid pathology in cognitively normal. So really, we can now detect very well preclinical Alzheimer's disease using blood biomarkers, not only amyloid PET and CSF. But the question is, should we do it? And this is something that I would be happy to discuss with you later. Osorman, what he did is, again, using our alpha cohort, our longitudinal data, in that case, instead of using the proteomics or Link or SomaScan, as Federica was using, is using the plasma biomarkers, measured here at baseline. And what you can see here, this is the beta estimates of the association of baseline biomarkers and the cognitive change. So a negative beta means that there is an association with cognitive decline at follow-up. And many of these biomarkers, again, at baseline, were associated with cognitive changes. This is, I have to say, sorry, at the group level. So when we look at individual level, we cannot take really an individual value of these biomarkers, and with this individual value, see whether someone will progress or not. But at the group level, there is this clear association of baseline measures of biomarkers and cognitive decline in preclinical stages of the disease. Very quickly, this is a recommendation that we did actually a couple of years ago already now. Pascual also participated from the Neurology Society of in Spain in order to give some recommendations to all the neurologists and clinicians in Spain on how to use blood biomarkers. I will go quite quickly. This is in Spanish. I think most of the things are quite common sense to use mainly phospho-tau217. This has to be asked for someone, neurologist or clinician that has experience on Alzheimer's and interpretation of biomarkers. But one of the last things that we said is that we should not use blood biomarkers in people that are symptomatic or cognitively normal. Something that I still do agree. But I think it's something that we need to start having a discussion whether we should do it in the future. There are now some clinical trials, like the HEAD study, that are testing anti-amyloid drugs in preclinical stages of Alzheimer's disease. If these trials become positive, they show that the work, we should still keep that. Should we start doing blood biomarkers in also cognitively normal people if we have treatments that show that we don't have it now, but if we have treatments in the future or near future that show that can really stop preclinical Alzheimer's disease, well, this is a debate that we need to start having. Let me show this. This is the Wilson criteria for doing screenings in the population, not for Alzheimer's, for any kind of disease. That these are kind of criteria to guide, especially the health systems, in order to decide whether you should do a screening of certain disease in the population. For example, some of the cancers, colon cancer, breast cancer, and so on. And look, if we apply this criteria to Alzheimer's disease. I think that we all agree that Alzheimer's is an important health problem. We now recognize early stage. That's why I started my talk talking about this continuum. Still now, some people do not believe in this preclinical or using other terminology at risk, but I think that most of the people recognizes that it is this presymptomatic stage. As I have already shown you, we have now tests that are able to detect this preclinical stage of Alzheimer's disease in a very reliable way, but we don't have now yet treatments that are targeted to these early stages. But if we have them, if that becomes blue, what next? Of course, we have to take into account other things. Cost effective, then we have to have a system that is prepared for that. But I think that we need to start having this discussion, because maybe at some point this turns to blue and we are not ready for that. And we have the technology to detect preclinical Alzheimer's disease. All right, let me, in the last part, talk about more the experience of the patients, because I'm showing here that plasma biomarkers are very, very accurate, are really able to detect Alzheimer's disease. We are using it in the clinics, but does this change something in the patient? Does we improve the patient management with that? That's why it's so important to have not only accuracy studies, but also clinical utility studies. And this is what we did, and this is very preliminary data that hopefully we will submit soon. But basically what we did is, if you are familiar with AMI-PET or IDEA studies with amyloid PET, something similar but with blood biomarkers. What we did is that during 9 months or almost a year, every patient that was coming to our memory clinic, almost everyone, we randomized it in 2 groups, this blue and this purple group. This we call it the early disclosure blood biomarker group, and that was the late disclosure blood biomarker. We did all the routine things that we do in our patients. And in this early disclosure group, before the 3 months, we had the blood biomarkers measured, phospho-tau217 and neurofilament, and we disclosed it to the neurologist, to the patient, and to the caregiver. While in this late disclosure, at 3 months, we did not disclose the blood biomarker to none of them, but we disclosed it 9 months later. In the end, we always give the blood biomarker, but with different times. And then we compare especially this visit 1 with this group in blue early that had the blood biomarker and this late group. And the results that I will show you will be always comparing these two groups. And what we could see is the following thing. Again, blue, early disclosure, purple, late disclosure. That was visit 1, and this is the confidence in the diagnostics on the etiological diagnostic made by the neurologist. And as we can see, if the neurologist had the blood biomarker, they were more convinced about the etiological diagnosis. Then in visit 2, also the purple, the late group also had the blood biomarkers, and then this converge. This is the confidence of the neurologist. But more important than this is probably how the diagnostic changes. Here, the early group and the late group at visit 1, of course, there were more changes in the diagnosis in the early group. And more important than this is the patient management. So again, the blue, the early disclosure, purple, late disclosure. What we can see is that in the early disclosure group, we were starting treatment before that in the late group. Or we were starting cognitive therapy before that in the late disclosure group. But there were some interesting things. So what we see, for example, is that we discharged from the memory clinics more people in the early disclosure group. And in the late disclosure group, we were having more repeated memory cognitive tests, probably because we were more unsure of what was the diagnosis. Actually, you can see this classified by the result of phospho-tau217. What happened is that in those people in which we have a high phospho-tau217, we were starting the treatment, pharmacological and non-pharmacological, before the delayed disclosure. But also very important, those people that have low phospho-tau217, we were discharging the early group more, while in the late group we were doing more cognitive tests. So having the blood biomarker disclosure as soon as possible really improves and makes more efficient the visits of the patients. Communication, I told you before, and this is also biomarkers research, not only the proteomics, the Olink, the SomaScan, how we communicate the results to our patients. And that's the infographics that we use, and happy to share it with you. We have it translated in several languages. And this is like a little bit like the ATN classification, with the horizontal axis, the cognitive status, subjective cognitive decline, MCI dementia, and in the vertical axis, the result of the biomarker with this two cutoffs approach. So if a patient comes with a subjective cognitive decline and has a biomarker that is low, we say to the patient, well, you are here. And we give that paper, and we mark this, and we said, you have a subjective cognitive decline, and it's very unlikely that this is due to Alzheimer's disease. Or you have a mild cognitive impairment, and it's very likely that this mild cognitive impairment is due to Alzheimer's disease. Or you have a dementia, but we are not sure whether this is due to Alzheimer's disease or not, and maybe we need to do a lumbar puncture or amyloid PET. That's how we communicate the results of blood biomarkers to our patients using these infographics. In our area, Hospital del Mar in Barcelona, the education of the people, it's much lower than other parts of the city, and actually some people cannot even read or write, so we need to use this kind of more graphical ways to explain the biomarkers, and we have to explain the biomarkers to them, of course. And talking about our area, so this is just to show, this is a Barcelona map in which it is divided in 4 main university hospitals. This is the area of a hospital clinic, Vall d'Hebron, Sant Pau, and Hospital del Mar. And here there is, and this is the primary care centers, and here in this primary care center, which is the Raval, around 60% of the people were born outside Spain. And these people, we don't see frequently to our memory clinic, because of course there is always a barrier, a bias, and although we have a universal public health system, sometimes we don't see it in our memory clinics. And that's why it's very important to work with the primary care physicians. And actually what we are starting next month, hopefully, is a project called DBAT Barcelona, in which what we will do is to do blood biomarkers. We will start with cognitively normal people that usually go to primary care centers. We will compare the 5 most frequent ethnic groups in that population and see whether the biomarkers are the same, because these cutoffs that I showed you before are cutoffs that we validated in our population, that 95% are white European. These cutoffs can also be applied. Actually, we are applying to our population, but maybe they are wrong. So we have to also validate this cutoff to all this population. So this is the study. And with this, I will finish thanking to all my group, and thank you to you for the invitation. Thank you.
Thank you, Marc. Do we have questions?
Thank you so much, Marc. Yeah, I'm very curious about the predictive values in the preclinical population. That, of course, is so challenging, and it's so important if these treatment are going to be useful. Not only useful, but they have to be worthy, because they are expensive, they have secondary effect, and we have to consider if giving them to asymptomatic people is a bigger decision for us clinicians than for symptomatic patients. So what do you think about how deterministic can we be with the biomarkers that we have right now? of course, we cannot be 100%, but our probabilities enough would you give this treatment if they work in a population level as an average in a trial?
Yeah, this is I think that we clearly have biomarkers that are very good for diagnostic, or other people will call it detection. So I believe that these biomarkers also in preclinical stages are good to detect amyloid or Alzheimer's pathology. However, we also need better prognostic biomarkers. Should I show that this data from Arman, that at the group level, baseline blood biomarkers are associated with cognitive decline, but at the group level. So we cannot use individual levels of blood biomarkers to see which of these in the cognitively normal individuals will really progress. And this will lack this. So how I see the future? I see that we have to increase the pretest probability. I don't see a future in which we do blood biomarkers to everybody in the population, and with that we start anti-amyloid drugs in this population. I think that we need to, in the general population, detect people that are more vulnerable, and then that means that they will have also a higher probability of having Alzheimer's disease and a higher pretest probability, and then the predictive values will be higher. How we define this more vulnerable population? Well, that's a difficult thing to discuss. Some people may say, well, maybe we have to go to people that are APOE4. I don't think we can do genetic tests to the general population. But we know that there are people that have higher cardiovascular risk factors, that have familiar history of Alzheimer's disease, sporadic history. So all these things may have to detect those people that are more vulnerable, or other things, or other biomarkers that are not biomarkers of Alzheimer's, but biomarkers of vulnerability to the disease.
But you showed that subjective complaint is not a good phenotype to reach the population, right? So,
well, it is. There is this definition of SCD plus, and plus means that you are more prone to have amyloid pathology. Actually, it's not the same an SCD of a person that seeks medical advice that from the general population. If I ask here, have you ever had any of you a memory problem in your life? Many people will raise their hand, but this is quite different. That really go to the doctor, or some relative take you to the doctor because you have these subjective memory problems. So here there is already an increase in the pretest probability.
Okay, you can reach the population and increase the test, but on the other side, can you do better with the biomarkers? Do you think we can complement with proteomics or whatever, or are we reaching the limit of the prediction that we can achieve with the 17?
I think for detection, I think it's very good. Maybe we need to adjust some things, because we know that phospho-tau217 can be affected by some drugs, by some comorbidities, by ethnic differences. So we have to study a little bit more of this. But probably I think that with phospho-tau217 will be enough. The issue is not only detecting the pathology, but detecting these people that having the pathology will progress quicker, and so need to be prioritized. And for that, we don't have good biomarkers.
I have two small questions about the finding you presented at the beginning of the talk on the difference between males and females. I didn't clearly understand whether this difference in the proteins that were associated with cognitive decline or with pathological markers of Alzheimer's disease.
Cognitive decline. All the people that we included in this study are people that are amyloid positive. So they are in the preclinical stage of Alzheimer's disease. And then we were studied whether within this preclinical stage people, there is heterogeneity. And some people are stable, some people decline, some people improve. So these proteins at the beginning, at the baseline, were predictors within the preclinical stage of Alzheimer's disease, are associated with a better or worse cognitive outcome. Not exactly.
We can extrapolate
Mm-hmm.
to
Well, actually, we can do that because we have also longitudinal amyloid deposition. We don't have longitudinal tau PET. Probably some proteins were maybe the same that may overlap, but others not, because you can, there's this definition of resistance and resilience. So some proteins make you more resistant to primary pathology or more vulnerable to primary pathology, that it's amyloid and tau. But then once you have it, then you can be more resilient or vulnerable to the effects of the pathology. So, and I think that some proteins or some mechanisms may be the same, but others may be completely different. So I would expect not the exact proteins. I would expect other proteins that are different. However, to do that, we should go even earlier. So we should take our participants that are amyloid negative, and then during the follow-up, they progress to amyloid positive, that we have a few, but not many, and see whether there are proteins that predict that.
All the things that the different, the prevalence, the incidence, the different in the level 6. Question is, you are extrapolating the evolution in Alzheimer's disease because you have the first marker side, but there are many things that can happen.
Yeah, of course.
Cognitive changes.
Yeah, definitely. I mean, this one advantage, but at the same time disadvantage of the alpha cohort, it's very pure, if we can say this, a preclinical Alzheimer's. So it's most of the people have a relative that had sporadic Alzheimer's disease. So it's enriched for APOE4, it's enriched for risk factors. They are very otherwise healthy people. They don't have major comorbidities. They don't have, for example, major vascular problems that in the neuroimaging. So it's very preclinical Alzheimer's disease. This is an advantage in the sense that you can really study the mechanisms, but it's a disadvantage in the sense that, of course, it's a very biased accord. And obviously, there are other factors besides primary pathology that affect the cognitive changes and need to be taken into account. Yeah, definitely.
Also to the sex, there is any relevant difference in the most used biomarkers of plasma biomarkers of Alzheimer's disease? There is any difference between sex?
There are, yeah.
Sex in order to make a prognosis to
Yeah. Exactly. So here we were looking at proteins associated with cognitive changes, but there are differences just in the levels of some of the biomarkers. A very good example is plasma GFAP, which is higher in women than in men for whatever reason, but this is very constant and very clear. Usually, the NFL and vascular factors are usually higher in men than in women. For SOTA217, there are some tendencies to be a little bit higher in women than in men, but not always clearly significant. So, and the synaptic biomarkers, for example, neurogranin, is usually higher in women than in men, for whatever reason. But there are these interesting things. And there are some funny things on the glial biomarkers. For example, progranulin is higher in women in blood, but higher in men in CSF. What does it mean? I don't know, but there are interesting differences. Yeah.
Okay, I just have a quick follow-up to what Theo was asking in terms of the difference between male and female. Do you have any data on starting age of menopause or other kind of like other biomarkers like that you can maybe correlate or find any relationship to?
Yeah, that's very interesting. And most of women, obviously, in our core are in the postmenopause. They are above 50 years old.
So you said that you recruited between 45, well, but they were almost.
Yeah, exactly. And most of them, although the initial inclusion criteria was 45, 65, most of them were above 50. So we have very few that are premenopausal. But definitely this is extremely interesting. And actually, what we are trying to calculate is the extrosion exposure. And there are, I mean, a very easy but very simplistic way to calculate it is just the difference between menopause and menarche. But of course, this is very simplistic, no? And we are trying now to have in our course other different hormonal treatments, other things that we can really calculate this extrosion exposure throughout life, because I think this is extremely interesting. Yeah.
Hi, I have two questions. One is related to the sex differences. So I was wondering, seeing the early result that you showed about so little overlap
Yes.
in the proteins.
Mm-hmm.
So I am left wondering, is it so little that one says, okay, does it say really that there is so little overlap, or that a lot of those proteins is just noise? So that I mean, you would expect at least a little more overlap, and of course some difference, not everything different and something very small overlap. So I'm not in that field, so I don't know how you can consider it something noise or not. But I'm just wanting to ask the muddy questions in a direct way.
Yes. No, this is a very good point, and probably we need to communicate it better in the sense because these are the proteins that are significant in one group, in men or women. That a protein or whatever is not significant doesn't mean that there is not a real association. Maybe we just cannot see it because there is not enough power, because there are co-founders, because there are noise, and so on. So it's true that when we see that this 3% interpretation should not be that men and women are similar, only the 3% of the blood content in relation to the blood proteins that are associated with cognitive decline. This is not the interpretation. I'm showing just this just to indicate that really we see a lot of differences. Actually, what we even see is that some proteins have an opposite effect, that some proteins that are associated with decline in men or women are associated with a better cognition in the other sex. But your point is very good when communicating this.
I am a Bayesian, so
Okay.
I don't have significance anymore.
Okay.
So my sensation is that there is a problem of threshold level.
Yeah.
If you increase your threshold, then things will become a little bit more reasonable.
Yeah.
So it's
You're right.
that the threshold is too low.
Yeah.
But it's personal, and I'm not seeing the data. But so let me go to the other question.
Yeah.
Since you correctly insist a lot on the pre-test
Yes.
probability of having the disease, so my question is, are the epidemiological data good enough to make good estimates of prevalence relative to the local area, relative to age, relatively to sex, relatively to whatever stratification one might want to have? Or should there be more active population-based studies giving better stratified prevalence data to make more better estimate of those positive predictive values? Where do we stand on the epidemiological side of the equation?
Okay, this is not epidemiological data, and it doesn't have the aim to be epidemiological. But your question is very good, and actually, it was published. Yeah.
Thinking at the health system
Exactly.
level, where the treatment are coming around the corner, should they invest a lot of money on epidemiology or not?
Exactly. So this is the point. So when we think in biomarkers, you always have to think in the context of use. So if we want to apply biomarkers in a memory clinic, we don't want to do epidemiological study. We need to know the population that we see in our memory clinics, and not only in my memory clinic, but in several memory clinics. Or if you want to apply the biomarkers in subjective cognitive decline, you have to get to know this population of subjective cognitive decline, and this is representative of your target population, the context of use. Having said that, if we want, as you said very well, if the public health systems want to do policies to prevent Alzheimer's disease, they need to know what is the prevalence of Alzheimer's disease, and not to say of preclinical Alzheimer's disease, and this is not known. There are few epidemiological studies. One of them, we were discussing it before, was published in Nature a couple of months ago. It's in a Norwegian epidemiological study. There's also a very good epidemiological court, there's NAC court in Karolinska Institute in Sweden, and there are other initiatives. But it's true that there are not so many real epidemiological data on the prevalence of these diseases using biomarkers, and this is something that I think should be a priority. Yes, because the policymakers need to take decisions on that, and we don't have data to take decisions. Yeah.
Thank you for the wonderful
Thank you.
presentation, Mark. I was wondering that I think in the second sentence or third sentence of the talk, you said something that was noticeable to me. You said that in the alpha study, a lot of people is amyloid or tau positive. And I wonder how you can put this into proportions, because if I'm in the ballpark correct, like general population about around 50 should be less than 10% amyloid positive. I know it's enriched in several ways, so I wonder which is this proportion I ask, because if you have a prevalence of 10% and a biomarker that has a negative predictive value of 91 would be comically bad.
Mm-hmm.
Because
Yeah.
just a biomarker that is always negative will have a negative predictive value of 90%.
Yeah.
So I wonder if you could illustrate us on which is the amyloid positive.
Yeah, so it's a third of them. I was not very precise exactly, but of course it is very enriched. Actually, a third of alpha core are amyloid positive, and the half of the people are APOE4. Obviously, this is much higher things of what you would find in the general population, because this is not a core epidemiological core. It's to study preclinical Alzheimer's disease. Something that's quite also interesting is that I said a third are amyloid positive with CSF beta 4240. But as we are in these very early stages, depending on what you use, can change a lot the prevalence. If you use amyloid PET, we have many people that are CSF positive but not yet amyloid PET. Depending on the cutoff that you use, 12 centiloids, 24 centiloids, 30 centiloids, then the prevalence change a lot, yeah, because it's a continuum.
I wanted to ask you more of a philosophical question.
Yes.
That is related with the use of cutoffs. So I always get my eyes open, because it's very popular, this concept that when you use their biomarker in the preclinical population, you have to lower the cutoff because you need better sensibility. This is a clear mistake on how sensibility and specificity work, because if the prevalence is low, its specificity is more important. So I wonder, when you showed again the negative and positive predictive value, so the positive predictive value was around 0.5, 0.6 in most of the biomarkers. So I wonder, like, would you, as a clinician, give more credit to a higher value? I mean, I think we all understand that even with 0.32 of the threshold, if a value is 0.9, the probability of being positive is much higher. So I wonder how in the clinic this value should be interpreted, and also how we need to teach other neurologists that are not as familiar with these concepts as you are, to really use this information in the full power.
Yeah. So for the first part, I completely agree with you that you should only use cutoff if you need to use cutoffs. Many people, when they ask for us alpha data, they ask me, do you have the cutoff for GFAP, the cutoff for phospho-tau 181? I say, no, I mean, yeah, I can calculate it against our standard of truth, but you really need it, because we're talking about a continuum, and I can calculate cutoff you in very different ways, depending on what you want. If you want to detect people that have subtle changes in amyloid deposition, or if they have overt pathology. So you should only use cutoffs if you really need to use cutoffs. And I think that for research purposes in preclinical Alzheimer's disease, most of the times you don't need to use any cutoff. You just use the continuous values. Having said that, in the clinics, we have to take decisions. And neurologists and clinicians, we tend to be quite simplistic, And we need to take decision because we have to communicate to our patients if they have Alzheimer's disease or not, or we have doubts, or we have to start the treatment or not. That's when we need cutoffs, but always interpreted in the clinical context. And regarding the values, yeah, of course, you can put different cutoffs depending on the predictive values. Actually, there are some clinical trials that they want to ensure that they include really Alzheimer's disease, and they put a very high value of phospho-tau 217. Many people that have Alzheimer are excluded, which is very unfair for them, but they make sure that you have an extremely high positive predictive value. Again, depending on the context of use. I'm not sure if I answered what.
Yeah. And I asked because this is I think a very interesting topic, because then we should reconsider how we compare the biomarkers, because the dynamic range of all of them is not the same. Actually, we have some nice example with our data from Vallecas.
Uh-huh.
When we go to very high values, we have the C2N and
Yes.
the Fuji review, and the C2N, it seems to have a higher range of
Yeah.
with the higher values are more predictive, and with the Fuji review is not as much. So I wonder, using these numerical values would change a less the comparisons, like how we should compare the.
Yeah. Here, what I would say to you, maybe there is here a more a biochemical reason, because an immunoassay and ELISA is always compared to a standard curve, and the standard curve there always a plateau. So there will always a limit on the values that do not follow a linear relationship in any kind of immunoassay. So you have a very high values, then be careful with the immunoassays. Yeah, and Lumipulse is an immunoassay in the end.
Thank you.
Thank you.
I would like to ask if an index combining GFAP and p-tau 217 was tested, and if it could make sense or not, and why.
Okay, I think for detection or diagnostic, I think phospho-tau 217 again is good enough, and probably adding GFAP does not add too much. Also, these biomarkers are quite correlated between them. What I wonder is maybe for this prognostic that we don't have, maybe the combination of some of the biomarkers could be helpful. For example, something that we did is that in this intermediate zone, we tried to see whether having an additional biomarker besides phospho-tau 217 like G5P can help a little bit. And actually it helps a little bit to from this intermediate zone, those that are in the middle of phospho-tau 217, if you on top put the G5P, it can help to discriminate this intermediate to amyloid positive or amyloid negative. It helps a bit.
Thank you.
Thank you.
Hi, Mark. Thank you for the presentation.
Thank you, Orfeas.
I would like to ask a question similar to Marina's. Like, do you think there's a benefit in integrating data for diagnostic purposes? Because in the literature, you see a lot of these like machine learning algorithms integrating imaging data, digital data, also blood-based biomarkers. Do you think they add a benefit over the conventional AD workflows?
Maybe here I have to say, and maybe it's prejudice. I'm maybe skeptical in this as a clinician, these black boxes that you combine different proteins and biomarkers, and then they tell you something. Having said that, maybe I have to change my mind, and because we are not used clinicians to do that, because clinicians we have blood tests that are with some cutoffs, positive or negative, and we take a decision. We don't usually use these black box algorithms, but maybe that's the new medicine. In the end, if medicine is an empirical science, so if that works, whatever if that works, then we have maybe to move to that, if the studies are well done, because you see sometimes some studies that they take a core, they don't replicate, they do some training, but then don't really validate it. They are not very generalizable results and so on. But if it is well done and really it works, maybe we have to change our mind.
I can contribute to the discussion. Say that to the first part of the question, integrating more information helps. I think doesn't require a machine learning algorithm. I'm pretty sure for you as a neurologist, if we give you an amyloid PET, tau PET, and an MRI and 7 plasma biomarkers and more cognitive data, you can do a much better diagnosis.
Yes.
A photo of the patient.
Yeah, actually, it's true. It's what we do, clinicians, that with different tests, but in just we have that clinical feeling more than really exactly, which is also a black box.
So thanks, Mark, again for
Thank you, Michelle.
that presentation. I think I want to follow up on the philosophical question of using thresholds, because you correctly mentioned that you should use thresholds if you need to use thresholds, right? And as clinicians, you need to make decisions. And then came the part that was interesting to me, I want to discuss about, because we need to tell our patients if they have Alzheimer's disease or do not have Alzheimer's disease, or if we're not so sure. And if you think about it, this is really different of how other biomarkers in the clinics are being interpreted. If you get a standard blood test, you get all kinds of blood biomarkers,
Yes.
right? Leukocytes, erythrocytes, whatever kind of, I don't know, there are 20 different things, and they're all reported on a scale. And you have a single star or 2 stars or asterisk, 2 asterisks or 3 asterisks, and then you as a patient know, okay, that seems to be a bit off, or here I'm very off, but none of these tests tell you have whatever, or.
But there are cutoffs.
They're cutoffs, but they're like judging by the 3 asterisks that you can get on some of them.
Yeah.
There should be at least 2 different cutoffs, so or actually 3 different cutoffs for each of these different tests. And usually you say, you get an asterisk here and an asterisk there, and then you go to your doctor and you say, oh, everything's fine. So because they are all interpreted together and in the big picture.
Exactly.
And if there's one deviation, then doctors usually don't care so much about it.
Yeah, exactly. So the diagnosis in medicine always are clinical, always. They're not based on just a blood test or a CT test or MRI, they are always clinical. And that's why I was showing this pretest probability. So we have to interpret the blood biomarkers in the clinical context, but not only blood biomarkers in Alzheimer's. Everything needs to be interpreted in its clinical context. That for sure. So that's why it's so dangerous. These people, and it's happening, that goes to a private lab. They ask for the phospho-tau217, and they have a result with an asterisk or not. And then what? Because someone has to interpret this biomarker, and not only this, someone have to request this biomarker, but for answering a clinical question. So the clinical context, the pretest probability. So I completely agree with you that, of course, it's not. Maybe I frame it. I didn't say it good enough. It's not a phospho-tau217. You have Alzheimer's, or not. You don't have Alzheimer. The neurologist, based on this result and based on the rest of the clinical picture, will take a decision whether you have Alzheimer's or not. Yeah, clinical context matters. But in the blood test, we need to, the values are important, and we need some cutoffs. Good example is the CSF. For example, in CSF, many companies want to push or wanted to push for the ratios, because then you have a single value, a beta 40, a beta 42 phospho-tau181, and it's binary, positive and negative. And I always say, well, it's better to look at the 3 biomarkers, beta 42, phospho-tau181, and total tau. And sometimes all of them are positive, sometimes all of them are negative, but sometimes there are some discordances. Then the clinician needs to interpret this carefully. But obviously for the industry, it's better to say positive and negative. No, things have to be interpreted in the right context, even the values. It's not the same if you have a phospho-tau217, it's just in the limit that is clearly positive and negative. Of course, and you have to see this.
So following up on the philosophy.
Okay, philosophical.
once we move away from the clinical diagnosis of the disease when it's already present, and we go early, then really a binary diagnosis becomes problematic.
Yeah.
It's really a probabilistic diagnosis. So in a sense, the change of thought in the communication and in the reception, of course, the patient expects a yes or no, but maybe the big change of mind is more of a society to be, okay, you have a little more or a little less probability, and are we ready, or are patient ready, and doctors to talk in terms of probabilities and not in black or white. So we like the binarization. Our brain feels comfortable in psychologically more comfortable in binary stuff, but maybe we should go more into the gray areas and starting to be more comfortable about the gray.
I completely agree, especially in the very early stages. I would be very careful with someone who is cognitively normal and has a biomarker that is positive to say to them that have Alzheimer's disease. Although from research purposes, I would say preclinical Alzheimer's disease, but to communicate it, I would communicate it in another way. So communication again is biomarker research. Here we can maybe look at examples of other diseases. For example, cholesterol. Cholesterol. If you have high cholesterol, doesn't mean that you will have a cardiovascular event, but you are at higher risk, and you have to communicate this to the patients. And not only this, you will take decisions maybe to start a treatment. You're starting a decision. Exactly, but it's true that the communication is different because you are not diagnosing a disease. You are saying that you have high cholesterol, and that puts you at higher risk of having a cardiovascular risk, event. Maybe we have to frame it in this way for preclinical Alzheimer's disease, and when we use biomarkers. There are other options. Let's take, for example, the example of HIV, in which we use different terms, HIV positive or having AIDS, because communicating AIDS has a lot, unfortunately, of still problems in that kind of terminology. Also, if you say Alzheimer's, that is perceived in a not good way for many people. Should we use different terminologies? Maybe that's the way to go. But if someone is HIV positive, you will start the treatment. You will not stop. You will start the treatment, and you have to diagnose these people as soon as possible, because you have treatment in this Wilson criteria. So you have to do screenings or go to the more vulnerable people to really diagnose it and start the treatment. So yeah, we can frame the communication in different ways, but we have to do something. Names are important. Very philosophical today.
I think that all this discussion be clear if we assume that fact that with biomarkers we are in fact estimating the present absence probability, the pathology of Alzheimer's disease.
Yeah.
Not the Alzheimer's disease. If we assume that, problem is we can identify Alzheimer's pathology, but problem is to identify who having this pathology will have Alzheimer's disease. And this is a problem. We have to, in my opinion, with these biomarkers are, all of them are validated. The standard of truth talk about are always of the biomarker, of pathology. So my last observation is the problem is when we can make the prognosis of Alzheimer's disease, having identified the Alzheimer's.
Yeah. Well, the definitions of diseases, and I think many people will agree here with me, are pathological. So that's how we define the diseases, with the pathology, not with the symptoms. The symptoms are the expression of this pathology. Having said that, the Alzheimer's disease is well, but no, more or less. I think in Alzheimer's it is a bit different because there is this difference between also the timing. If you have a cancer and you're asymptomatic, you will develop this cancer in a more or less short time. In Alzheimer's, it happens, it lasts a lot of time. Not only this, that also there's a lot of heterogeneity, and some people are resilient, more vulnerable. So all this complexity makes also the terminology more complex, and I understand this.
There are no more questions. We can set you free.
Okay, thank you very much.